was running to talk this week.
Sorry, I'm about to start editing my slides for this afternoon.
I was online for tomorrow, so I'm just, yeah, I had this.
Oh,
the
you got
MRF
two questions. Oh, you
I
got-
had two for-
Oh,
but
right.
The MRF was due today.
Oh, yeah, yeah.
Well, due tomorrow, but Tuesday.
Mm. We missed out on. I was lucky I was actually invited from another discipline to be
Oh,
part of one.
nice.
Because I've, it's hard in a very small discipline. It's really difficult to be working in that space.
Yeah,
I'm just lucky I'm collaborating with other disciplines doing that sort of stuff. Mm.
and I've tried to make it on.
Yeah, that's good. Okay, look, just generally speaking, it's a 5-minute talk with 5-minute questions. And our first speaker is Lisa, who, a bio.
Yeah, so I was in the father. Hi, Lisa. This is Lisa Hudson O'Donnell. Lisa is a research fellow in geriatric pharmacotherapy at the Colin Institute, which is at Royal North Shore Hospital, and part of the Faculty of Medicine and Health here at Sydney Uni as well. She's also a clinical pharmacist educator within the School of Pharmacy, and her research focuses on optimizing the qualities of medicines in older adults.
Okay, Lisa, I'm going to start if I won't give you any warnings. Okay.
That's fine.
Okay.
Thank you, everyone. And so, yeah, good afternoon. My name is Dr. Lisa Fledgen O'Donnell, and today I'll be providing a short summary of a national survey to determine the process of conducting medication reviews by Australian consultant pharmacists. And this work has been conducted in collaboration with Kenneth Lee, Amy Page from the University of Western Australia, Amanda Cross from Monash University, and Deborah Hawthorne, who's a consultant pharmacist from Victoria. And we've collectively called ourselves Coherence, the Consultant Pharmacists Services Research Network. So home medicine reviews are a government-funded pharmacist-led medication review service, and these services are usually provided by consultant pharmacists, or CPs as I'll call them from now. And these pharmacists usually undergo specialised training and annual reaccreditation to conduct these services. During a HMR, a GP refers a patient to a consultant pharmacist for a number of reasons. And, for example, such as, suspected adverse drug reactions. And the CP conducts the interview in the patient's home. The CP usually writes a written report to the GP, and the GP then sits with the patient and they both agree on a medication management plan. Although most consultant pharmacists are trained under the same competency framework, little is known about the consultant pharmacist's conduct of the HMR services during the various stages of the service provision. So such as before they see the patient, after they see the patient, when they write the GP report. So it's important to investigate these, as sometimes these can affect the quality of the report that's going to the GP. So the aims of our project were to explore the information and information gathering and report writing processes that consultant pharmacists use to conduct the HMR service. We created and validated a survey that we distributed online to conduct a cross-sectional analysis of consultant pharmacists. We used the 5-point, the questions included 5-point Likert scales and multiple choice questions. And we had various questions that we asked of the participants, such as the types of information in a HMR referral, the types of information included in a HMR, and the tools that they might use during the process. So there are approximately about 2,500 consultant pharmacists in Australia, and for our study, we had 269 who participated consented to participate, and there was 175 who completed the survey. So this is a summary of just the key characteristics for some of these participants. 76% were female, 97% had accreditation through the Australian Association of Consultant Pharmacists. There's 2 accreditation pathways. So there's the Society of Hospital Pharmacists and the AACP, and majority of the participants were through the AACP accredited. The people who participated were mostly from New South Wales, so 25%, and most of them were actually practicing in the metropolitan setting, with the rest in rural or remote settings. So this might look a bit, a lot, but I'll try and navigate you through it. So what we did was we mapped the type of information that is given in the GP referral to the type of information that is reported back to the GP in the written HMR. And as you can see, past medical history and the medication list and allergies and adverse drug reactions is the most often provided in a GP referral, with minimal amount of information about family and social history. However, we're glad to see that 100% of pharmacists reported the medication list back to the GP. So that's the main idea of getting a HMR. So that's really good to see. But also we've also seen that there's a big trend towards providing some social history. So this could allude to the fact that pharmacists are providing medication recommendations whilst considering the patient's social situation and living conditions as well. So that's a really good thing to see as well. We asked the question, how often do you typically use the following clinical tools to assess aspects of the patient's health and or therapeutic management during the patient interview? And we had 186 answer this question. And we found that, yep, sorry, 5 minutes to nearly finished. We found that a majority of these people were using the anticholinergic burden measures and adherence measures, as you can see here. With very minimal uses of other types of scales used in research, for example. So our survey explored the extent of the information that is collected from patients and presented to GPs during the HMR process, although there were several points of bias. So some of the pharmacists were self-reporting, obviously, what they collected and presented to the doctor. We did identify that consultant pharmacists are providing evidence-based and person-centered reports back to the GP. So thank you for letting me talk about this work. This is our group, Coherent, and our various Twitter handles. Feel free to connect with us. Thank you.
That's a very short time frame to actually put in all that work. Any questions from the audience?
Thanks, Lisa. I was quite interested to see that there's quite a lot of consultant pharmacists were using tools. Did they provide any more detail about, because you said, for example, like what type of tools they're using, and do they put those scores in the reports back to?
Yeah. So we provided these options of,
Yeah.
you know, do you use this tool, this tool, this tool, this one? They sort of tick yes or no for most of them. And the most common ones were the anticholinergic burden measure adherence, but we don't have the ability, I guess, to see if they're actually reporting that back in their reports. They might say they are, but to what extent or how they're doing it, we haven't analysed that further. There is a study that Kenny is doing over in WA with one of his students where he's requested reports from accredited pharmacists and he's looking to see what they actually use, so sort of thematically analysing that. So some of that data is on its way to being.
There's another question.
I can ask a question. How did you manage implicit bias?
Implicit bias, yeah.
You know, these are all people who know that you're looking for the right thing, and what do you think of that?
It's very hard to, you know, you just have to account for it when you're analysing the data. We tried to, you know, provide all options possible, but we did provide some other sort of comment boxes as well. So I haven't had a chance to present that data as well. So
Qualitatively.
there's some qualitative and answers that we had that we can present, but we don't have time. But it's hard to account for that implicit bias, but this is, I guess, just the beginning of this type of work. Then further on, as I mentioned, we're doing some more work with some actual reports of how people are writing them and sort of analysing what they're actually putting in. So,
I've just got a general comment. What are the average times to write one of these reports?
oh, well, the HMR, I think like the interview, like amongst like our colleagues, we've discussed this and we take the interview takes about an hour. Sometimes if they really want to chat with you, it takes about an hour and a half. Writing the report varies. Some people do use software, which allows them to sort of input their data and it pushes out a report. Others do write, you know, pages, but GPs don't have time to read those, you know, pages as well. So it's important to keep it as succinct as possible. Like I know that it takes me maybe, you know, half a day to maybe write one report just to get an idea of recommendations, making sure that medicine list is accurate, all those sort of
hard to
fine detail.
Enumeration $200+, you know, whatever that.
Yeah. Oh, yeah. Don't start me with that.
Thank you so much, Lisa.
Thank you.
Really good. Antonia.
Yes, everyone. Our next speaker is Anton Patella, who's just joined us here as a PhD candidate at Sydney Pharmacy School. He's lucky enough to get to come, who we've seen a lot of this week. So he's originally from Indonesia, where he works as a pharmacy lecturer at the Department of Clinical and Community Pharmacy at Universitas Jember. And the work that he's presenting today was part of the Wire Storage and Disposal of Medicines program, which was funded by the Australian government. Through an alumni grant scheme that the Australian government awards initially.
Thank you. I'm going to just press the 5 minutes and then just put my finger up for the last minute, okay?
Wait, I will delete my.
Just down the bottom,
Yeah.
just down the bottom, the little podium down the bottom.
Like his rehearsal.
Yeah. Sorry.
In slideshow or somewhere, and there's a way to remove.
This one. So sorry about this. Guys. So okay, I will show this way.
You just, the little podium, just do you wanna,
I don't think it's done.
oh, that's right.
Okay. Thank you. Good afternoon, everyone. So I'm Anton, a new PhD student here. I will not present my PhD topic, but I will present my previous work in Indonesia back in 2021. So during the COVID-19 pandemic in Indonesia, we saw kind of medicine stockpiling in the household because of rush buying. So people are rushing to not only buying the consumer products, but also pharmaceutical products, including the prescription medicines, OTCs, vitamins, and so on. And that's why there is a growing need of, increasing the awareness about the medicine storage in the household. And also there is a need to also increasing the awareness about medicines disposal in the households, because in Indonesia, and I think it's like in other developing countries in the world, we are kind of risky for counterfeit medicines. So while rush buying may lead to imbalance between supply and demand, the perpetrators can, recycle the medicines from the landfills. That's why when the people can dispose their household medication properly, it will be a lot of benefit for the society. And currently, there are actually some programs in Indonesia, nationwide programs, but my colleagues and I wanted to foster this program by developing a new program that have a specific messages for the society. That's why we conducted this survey. So the survey aims to get a specific messages that that we can tailor for our program. So we conducted a survey of cross-sectional survey in 3 cities of Indonesia, 2 in Java and 1 in Sumatra. So actually we provided the online questionnaire, but for the participants that need to have a face-to-face interview, it will be okay. But we make sure that everything are safe. So we provided kind of personal hygiene equipment for the surveyors. And the results from 89 respondents in 3 cities reveal 4 important things. So the first is the expiry date interpretation. The second is the use of refrigerator. The third is tactics of disposing medicine, and 4 is medicine sharing. For the expiry date interpretations, about 75% of our respondents answered incorrectly. That's probably because usually in Indonesia, the consumer products print their best before date in the complete format, the day, month, and year, while the pharmaceutical products they usually only print the month and year. So so our respondents answered incorrectly. And the second one is the use of refrigerators. In our respondents, not all, not most of them, but some of them usually store the liquid medicines inside the refrigerators. We know that this is not an appropriate practice, so I think this is need to be informed to the patients. And also the techniques of dispensing medicine. In Indonesia, we do not have a kind of Australia or Malaysia has. That the medicine written program. We don't have that. Such program was just piloted in 2019, but after the pandemic, we haven't heard about the update. So I think giving the information about how to dispose the medicine appropriately or wisely, because we don't have the system, the good system, then it will be give a lot of benefits for the society. And also medicine sharing. This is very important. Actually, in our survey, the survey revealed that not most of our respondents disagree toward medicine sharing, while it is actually not uncommon in developing countries or in communal society. I think that's because during the pandemic, it's not easy to get the medicines. So they want to keep the medicine only for their family or also for family members. I think that's all that I can talk to you. And I need to acknowledge that this project is funded by the Australian government via the Australia Awards in Indonesia. Thank you so much. I'm happy to answer your question, and I will be more happy if you don't ask difficult questions. Okay.
When you all mentioned that the respondents were misinterpreting the expiry dates, I was just wondering, how were they interpreting it? Were they suggesting like the beginning of the month that was listed as the expiry date, or the end of the month? Yeah, I guess what was the misinterpretation?
Because we in Indonesia only use the day, month, and year. We do not have kind of date, month, date, and year. Then it's okay for them to have, if they got the complete date format, and it will be okay.
Okay, so it's just when the day of the month wasn't listed there that they had to.
Yes. What I mean is that when in Indonesia, when the manufacturers only print the month and date, it means that the drug still can be used until the end of the month, right? So most of them cannot interpret it correctly. So they usually just answer that the first date of the month, it will be.
And it's valid until the end.
Yes. Thank you, Ali. Yes, Carl.
No, and I'll leave you one. Besides doing your PhD, have you thought how you're going to take this survey forward, these findings, with respect to developing your health promotion campaign?
Actually, this is the first phase of our program development, and we already developed the program. So we created 2 short movies from this as for the means of health promotion, as well as kind of Instagram posts and so on. So we already delivered the program to our target communities, 3 communities.
I've got a quick question, just with regards to the program, the government program, was there any incentive to do the right thing and be wise in the way you dealt with these medicines? Was there any sort of government incentive for the population to do the right thing?
No. And usually the Indonesian Pharmacists Association, they run the program, but it is usually only when they have celebrate their birthday, kind of, something like that. So it's not running every time, and it's not massive, the program for the government.
Thanks, everybody.
Okay, thank you.
Okay, we've then got one more participant, Jack.
Yep, I'm just gonna make sure that. I think I just make sure that you screen share. We're sharing this time.
And the bio.
Okay, so our last speaker for this mini session is Shafika Halim, who is a PhD candidate at the University of Queensland. And she's working with Karen, and Deb. And she's focusing on resilience and ways to enhance resilience in pharmacists and pharmacy students.
Okay, great, go ahead.
Okay. Hi everyone. Thank you for joining this session. I'm Shafika, currently a PhD student at the University of Queensland. I would like to express my gratitude to the community member for giving me the opportunity to present my research today. The topic is how early career pharmacists understand resilience, a qualitative study of experiences, challenges, and strategies. This is the outline for the presentation today. The presentation is part of a larger research project at recommending best practices in fostering resilience in pharmacy curriculum. So we're going to start with resilience. What do we mean by resilience? Anyone that has done research in this area knows that this question is not easily answered. Different scholars offer diverse meaning of resilience, and every single concept emphasizes a specific characteristic of resilience. Resilience now becomes a topical topic at the moment among healthcare professionals, as resilient healthcare professionals in overcoming challenges remain positive in the face of adversity and allow them to deal with challenging work situation and environment. Research is increasing about how early career healthcare professionals understand and maintain resilience, but little is known for early career pharmacists. Before considering recommending changes in the curriculum that may support the development of resilience, clarifying the concept with the early career pharmacists will ensure that their expectations are met and different concepts are not conflated inadvertently. Moving on to the aim, we do have three aims. The first aim is to explore early career pharmacists' understanding of resilience and their experiences in workplace. And the second aim is to investigate strategies and support that they may actually experience in the workplace. The last aim is to explore looking at the strategies that they think would work during their undergraduate degree or internship at the starting point for designing any resilient fostering program. So we use qualitative research approach, ethics from UQ. We invited early career pharmacists up to 3 years post-registration working in Australia. Why 3 years post-registration? Because they are the key informant and they just recently entered practice and they are close to their undergraduate degree to be able to reflect on their experience. We use face-to-face as well semi-structured as well Zoom to conduct the focus group and semi-structured interview depending on the availability of the participant and the contact restriction of that point of time. We use thematic analysis to analyze the transcript. So for the result, 3 focus group and 12 semi-structured interviews with total of 15 hospital pharmacists and 10 community pharmacists, total of 25 pharmacists were conducted. We identified 4 main themes that is closely linked to the research questions. I know this slide is a lot, but I will go through each theme after this. So for the first theme, when we asked early career pharmacists their understanding of resilience, they understood resilience as the capability to adapt to and learn from challenges and setbacks. They define resilience constructively as an ability to deal with pressure. They agreed that resilience can be developed by exposure to challenges and adverse experience, which is aligned with what we have found in the literature. So as the second theme, when we asked about challenging situations that tested their resilience, they reported that working environment and workload tested their resilience the most by not having to fulfill basic needs such as lunch break and difficult conflicts in the workplace, undermining their resilience. Both hospital and community pharmacists mentioned that inadequate staffing and casualization of workforce affecting them. The transition from intern to registered pharmacy also tested them, especially during COVID-19 pandemic. They found it challenging to take on the new responsibility, leaving the supervision of senior pharmacists to registered pharmacists, especially if they are the sole pharmacists working. So many pharmacists mentioned how COVID-19 changed their work procedures and adding extra pressure and undermined their support structures and strategies. For hospital pharmacists, COVID-19 isolated them from their peer and support system. The isolation actually influenced their well-being as actually reducing their social support in the workplace. As community pharmacists, influx of customer bulk buying, supply chain interruptions, and constant changes of the COVID-19 regulation added to the conflict and workload. They also struggle to support themselves, the support patient, and also other staff emotionally during this time. As for the third team, pharmacists were proactively seeking support in order to maintain their resilience, describing support at different level through self-care strategies and peer and organizational support. So for the fourth team, early career pharmacy perceived mentorship and sharing experience, and also experiential placement as important in building resilience during undergraduate degree. They mentioned that discussing the reality of work life with experienced pharmacists, as well as role play of difficult situation, such as difficult patient or interprofessional conflicts actually would benefit them. So for discussion, early care pharmacists have sophisticated understanding of resilience, are willing to work on strengthening and maintain their resilience. They identify resilient challenging testing, but also strategies to support them. Many of the challenges can be mitigated by structural and organizational support. Workplaces can support early care pharmacies resilient by monitoring workload over time, over extended period of time, and workplace relationship and creating opportunities for peer and mentor support. For take-home message, allowing pharmacies to employ self-care strategies, for which many include access to supportive network, avoiding situation of ego depletion as a result of excessive work hours and lack of breaks can easily support pharmacists in maintaining resilience, especially during COVID-19 pandemic. Early universities can actually use early career pharmacists' experience and insight, as it will be valuable when considering the design and implementation of resilient fostering programs. Universities may consider role play or challenging situation during undergraduate studies and mentorship during internship as resilient enhancing strategies. So this is the references I've been using. Thank you. Beyond
Your difficult to get all that information, so it's fine in 5 minutes.
a brief format. Can I thank all the pharmacists that contribute to this study. Thank you.
Any questions from the audience? No,
Thank you. That was a lot.
Sorry.
Trying. Qualitative studies are always hard to fit into 5 minutes, but I'd like you to talk to a point that I'd like to differentiate between resilience. The word resilience means it's highly challenged, and I would have understood more if you focused on the COVID challenge. Between that and the normal transition of any one of us from intern to professional, that is not about resilience. So I'm challenging you now a little bit about your understanding of resilience in the context of internship and transition. I feel it's a different notion.
Okay, because the aim of our study is actually to recommending best practices, which is the for the undergraduate degree and during internship. So we are using their insight, which is the early career pharmacist, which is the one who just just become intern. So we are using their insight, their valuable insight, so that we can actually provide something that can be done in undergraduate or internship program. So when we ask them about what are the challenges that they actually think will testing their resilience or undermining their resilience, they mentioned that workload, working environment, and secondly about the transition from intern to registered pharmacies. So that's why we are getting their insight. So the part of, yes.
Yeah, I think what Betty's saying, there's two sort of
Yeah,
areas
there's
here, and you're tapping, I mean.
Because we do have the professional resilience and academic resilience. So we are like this research is actually, we're gonna like link them together in a way that actually can be translated from when they already, because during the internship and during the undergraduate degree, so that we can actually translate while working, when they entered so as preparation for them to enter the working life. Yes.
Okay, so Carl,
I'm very much, it's a fascinating area. Thank you very much for your presentation. I noticed your third and fourth themes, and one of your solutions are with respect to connection or networking or collaboration.
or mentorship.
Mentorship. I was curious, going back to your method, that you use two different modes of data collection. You have semi-structured interviews and focus groups, one being one-to-one, whereas the other you have multiple participants. Did you discern any difference in the data you collected from, say, individual reviews versus when people were in the same room and able to talk with their colleagues?
Okay, because we use two different methods, which is the focus group and also semi-structured interview face-to-face. That because of during the COVID, it's hard for us to actually.
Of course. There's more a case of you've got serendipity. You've got two different methods now. Do you see a difference in your data?
Okay, in a way for us to actually analyze the data, because we are using the same set of questions.
Yes.
And then the same interviewer.
Yeah.
So the way we conducted it is actually the same. So the data doesn't actually differ much between each other.
It's interesting because if you've got other participants who might have an opinion, and there's, maybe some have more stronger opinions, and they
Yeah,
draw
that's
in.
why we use actually see the one who's actually very expert in qualitative. So she in a way like making sure each participant will have the time to say, to voice their voice. That's why we don't have actually like
You don't think there
much,
would
yeah,
be
even,
a difference, even though they're listening to other opinions around that table. You don't think there would be any difference to their answers?
because the way we conduct it is like we are giving time for each person to actually answer the question, for every single time,
Yeah.
every single question.
Yeah, I think it's not basically related to time, but you do, the whole purpose of the focus group, you are looking at all the other
Yeah, the flow.
perspectives, and your perspective might change because you're listening to someone else's perspective. So it's probably highly unlikely that you'll have the same answer on a one-on-one interview as opposed to the focus group. It's only something to think about.
That's why we use.
Something to think about in the future. Yeah. No, that's well done. Thank you very
Thank
much.
you.
Brief session, so if you someone else that you want to see in another session, there's a last opportunity in another session. But thank you very much for that.
Thank you very much, everybody. Thank you for your contribution and your. Very nice. Very nice.
Well, that's what I'm thinking. Someone can look at the time and do the other. Am I aligned with your? So Jack said and put mine in,
Where you guys finished in here?
yes, we had to have one,
Hey,
one for the region.
oh, so that. Well, very much stay. Like I did yesterday, so it's fine. I have all. Jack, when you have finished, just shut it, please. Yeah. Thank you.